So good evening, everyone. My name is Carol Annett, and I'm with the Sunnybrook's Board of Directors, and it's my privilege to welcome you to tonight's discussion. There are familiar faces in the audience, which is great, and if this is your first time with us, we're really happy that you've joined us. Tonight's discussion focuses on a health issue that many people are living with, obsessive compulsive disorder, or OCD. It's estimated that about 1 in every 40 people will be affected by OCD at some point during their lifetime. That equates to between 2 and 3% of the population. According to Anxiety Canada, OCD can begin in childhood. In fact, they say up to half of adults with OCD identify their symptoms starting early in life, typically between the ages of 7 and 12. As with many other conditions, OCD can be isolating, and it's really important to know that there are many possible treatment options to consider. And tonight we're so fortunate to have a jam-packed panel of experts to really dive into the impact of OCD on the brain, as well as existing and new treatment approaches. We hope you leave this evening with a better understanding of this condition and how these various therapies work. Moderating tonight's session is Dr. Peggy Richter, and Dr. Richter is head of the Frederick W. Thompson Anxiety Disorders Center here at Sunnybrook, which is the most specialized center in OCD and related disorders. There, she also serves as director of a new residential program for severe OCD. It's the only residential treatment program of its kind in Canada. Dr. Richter has been treating people with OCD, hoarding disorder, hair pulling, and skin picking disorders for over 2 decades. She's also involved in many research projects, including a focus on understanding the genetic and biological basis of OCD and ways to improve outcomes. Please help me in giving Dr. Richter a warm welcome this evening. She was instrumental in organizing this event and the expert panel of speakers you'll be hearing from soon.
Thank you so much, Carol. Really appreciate your coming here. Carol didn't tell you this, but she is here wearing several hats, actually, because in addition to serving on the board of the hospital, she's also, in her previous life, been very involved leading one of the main community mental health organizations out in the community, VHA Home Healthcare. So we're happy to have you here with us. It's really lovely to be here as well, to see so many of you, many, I think, returning faces that I know well. It's been a pleasure for me being here at Sunnybrook for the last 11 years and leading the Thompson Center for I think it's our 6th year now, roughly, to be able to host another one of these. I think this is around our 10th or so public speakers forum here at Sunnybrook on OCD and anxiety, and we're always delighted that we see so much interest in the community in these topics. I also want to just say a quick thank you before I forget to Monica Mattis, who is here somewhere tonight. She might have stepped out right now, unfortunately. She is with communications and is the person who leads the speakers series events at Sunnybrook and does a fabulous job and keeps it all running so smoothly. So I think we should all give Monica a big hand of applause. I want to thank you all for joining us. So here at the Bayview campus, we also have people watching this event remotely at home, and welcome to all of you. Our lecture tonight is called Treatments for Obsessive Compulsive Disorder, New Options and How They Work. And the reason we came up with this title was that, as usual, I wanted to cram everything possible into one evening. And after a bit of negotiating with Monica, we basically did anyway. So we're trying to give you a pretty jam-packed evening of great speakers and great talks, in which we're covering a bit of the basics of OCD, the treatments that are out there, but with a special lens or perspective in terms of how they impact on the brain, which most of the speakers will be addressing along the way, which I think is kind of different for one of these. And so I hope you'll enjoy that aspect of it. We do love feedback for these events. We always solicit it, and we very much welcome and will respond to it. So if people have suggestions of things that worked well or maybe didn't work quite as well as we would have liked, please do let us know. Can everyone hear me okay at the back? Good. Okay. So I'll be starting off tonight by telling you a little bit about OCD and how it impacts the brain. And I'll be coming back with more detailed introductions, but we're also going to be hearing from Dr. Marlene Tove-Schiff discussing cognitive behavioral therapy, which is the type of psychotherapy we use for OCD. And she'll be telling you more about that. Dr. Neil Rector will be speaking after that with a presentation on the role of exercise for OCD and what we know about how it may be working in OCD and on the brain. We then have Dr. Lance Hawley speaking, and he's going to be telling you really interesting new results we have about studies of mindfulness, a type of meditation, and about new knowledge and new tools developing in terms of how this can be used for OCD and related disorders. And finally, we're delighted to have somebody from outside the Thompson Center, but who works closely with us, Dr. Van Davidson, will be talking about neurosurgical interventions for treatment-resistant OCD. So truly cutting-edge work, and we're very fortunate to be partnered with the Hartwell Center here at Sunnybrook to do this kind of work and have these options available for people with the most treatment-resistant and severe illness. So we'll be coming back to those introductions. We'll be setting aside some time at the end of the evening for you to ask our panelist speakers questions. So each of you should have a small blank card on your seat. And what we do is we ask you to write down your questions at any time during the evening. People will be coming up the aisles like Monica is now and happy to take your questions whenever you've thought of them. And then I'll be going through them and making sure that we try and get through as many as possible in the question and answer period at the end. If you have a question written down, just raise your hand at the end of the talk and somebody will come around to get it. Feel free to get up if you need to during the evening. We will not be taking a formal break, so we will be going straight through till 8:30. There are washrooms located outside the auditorium, just over on this side, and there are refreshments outside as well for any of you that need something. Okay. And I think that's about it for my introductory comments. So I think I get to kick us off tonight and tell you a bit more about OCD. There we go. Okay, good. Let me just fix that. So by way of just orienting you to what I want to cover in this talk, and somebody's keeping time for me. Perfect, thanks, Lance. So what I'm hoping to cover is a little bit about what OCD is and looks like. A very, very brief introduction to drug therapy, just because that's one of the few topics that we thought really is often a source of questions that we otherwise don't cover in a talk tonight. And then I'm going to try and end the latter part of my talk telling you a little bit about what we know that is going on in the brain in OCD, which is really interesting and has evolved so dramatically since I started working with people with OCD about 30 years ago now, actually. So I know I'm dating myself a little more than Monica did there, but that's the reality. How many here have a relationship, either have OCD or had a relationship with a friend, family member, coworker with OCD? How many have had experience with it? Wow. Okay, so I have an audience here of people who are all pretty familiar with this topic to at least some extent. The interesting thing about OCD, though, is that it can look really different in different people. So let me give you 3 vignettes by way of introducing those differences. So imagine Kathy. These are all, I should say, fictionalized versions of patients I've met over the years. Kathy, when I first met her, was a lawyer, 32 years old, who had endless ruminations about contamination. She had really been unable to work since shortly after completing articling, after finishing her schooling, had really only worked a couple of years in a firm, had a very promising early career, and at this point was unable to work because she needed to wash her hands and her body for hours on her return. She was preoccupied with contamination and feeling dirty and had to ensure that her home was as clean as possible, which is why going out and coming back in became one of the most difficult tasks for her. She went around with plastic baggies and wipes to avoid touching things, and in fact, shortly after I met her, she moved out of her own apartment entirely because it felt so dirty, and had started living in yet another apartment to start over. Jamal had a rather different presentation. This was a lovely gentleman in his mid-50s. He was an engineer by training, and he had had to retire quite early because he had constant checking rituals. He would worry endlessly about making mistakes and the potential catastrophic consequences of any small error. And at the point I'd met him, he had long since been unable to function as an engineer, but his firm had been really accommodating and had eventually allowed him to change his duties to helping out with the mail until he was unable to perform that because he would be checking each piece of mail so many times it really became totally impossible. And Janice was a young mother in her late 20s. She was stay at home with 2 young children. She had become paralyzed with fears that she would harm her own children. And I want to just comment on this kind of a presentation because sometimes people find these types of thoughts in OCD the most frightening when they're thoughts of doing terrible things or harmful thoughts towards others. In that people with OCD dread these thoughts above all else. They're typically fears about the things they think are the most wrong things imaginable. And so people with OCD would not act on these fears. In fact, they usually structure their lives to do everything possible to avoid what they perceive as risky situations. So in the case of Janice, it was really very tragic because her thoughts would come on when she was looking at her kids. She would get terrible thoughts that she would harm her own children who she dearly loved. And it reached the point that she really couldn't nurse her young baby because she was afraid to hold her infant close for fear she would do something unwanted. And she developed quite severe depression at the time I met her because of this. So 3 very different presentations, all OCD. And so sometimes people say, well, then what is OCD? So OCD is linked by the quality of these features. We look for the presence of obsessions or intrusive, unwanted thoughts, but sometimes they're experienced as images or impulses that people perceive as really excessive or frankly uncontrollable and that bring on a lot of anxiety. And typically, they're tied to compulsions or rituals, repetitive behaviors that people do to somehow make themselves feel safe. And of course, in the case of washing rituals for people with contamination fears or checking rituals, they're things we can see outwardly, but because it can also be inward mental behaviors, having to think safe thoughts to somehow neutralize the fears, for example. Now, sometimes the question then gets asked, so how do we define or separate this from people who just have occasional excessive anxiety? And like in a lot of mental health, we don't have a biological test or marker, but we look for certain qualities. And the qualities we look for in the case of OCD are the symptoms either cause a lot of distress, waste at least an hour of time per day, or interfere with one's ability to function. And that's usually our threshold, at which point we would call this a case of OCD. So I've already touched on this, but again, just to bring home, OCD can then really be about anything and everything. In fact, very often what we see with OCD is that it gravitates onto those things the person with the illness most fears. It's a very clever disorder, and for that reason, it creates such immense inner pain and turmoil because people are plagued by these thoughts of the things they think are the most dreadful. Other types of OCD we may see are people who don't have a lot of outward rituals, which we sometimes term pure obsessionals. People who worry about things being correct, adhering to morality and religious laws, often termed scrupulosity, or people who will say it really can be anything or everything, but whatever I do has to feel just right. And if it doesn't feel just right, I do it again until it does. So I just touch the paper and maybe it didn't feel quite right, so I'll just lean over and touch it again and try and get that feeling of just right somehow, nothing else. Or mental contamination, where I worry about things somehow being tainted just because I had a bad thought while I touched them, for example. And so after a while, my entire world may become contaminated because I've had bad thoughts while looking at anything and everything. So why are we here talking about OCD? Most of us are much more familiar with major mental disorders like depression, bipolar disorder, schizophrenia, things that get a lot more airtime. But OCD is actually a major mental disorder right on par with those, although it doesn't get the same amount of attention. And some of the reasons for that are that it's very common. So as we heard from Carol, it affects about 2.5% of people over their lifetime, which is a huge number. The analogy I often like to give, because I think it conveys it in a more concrete way, is imagine 1,000 people at high school with you at the same time you were. And imagine that at least 25 of them, enough to fill an entire classroom, have gone on or have already developed OCD. And I think that really brings home how common, in fact, this disorder is. Moreover, it's been estimated that it affects about 10% of people who seek help for mental health issues. So we see a lot of people with OCD and other problems coming forward. It's also severe. So the World Health Organization at various times has listed it around the 10th to 15th leading cause of disability worldwide. I want to point out we're talking about things like alcoholism, cancer, heart disease, diabetes. We get depression on that list and OCD. It also carries a big burden because it's very commonly comorbid, as I mentioned, or co-occurring with another mental health condition. So in fact, it's more common than not that people with OCD have also suffered from episodes of depression. And this may be in part related to some shared biological underpinnings, and perhaps also in part the distress of dealing with such a severe mental health issue. Anxiety disorders, also very common and co-occurring, and what we call the OCD spectrum disorders, problems that Carol mentioned, things like hoarding, body dysmorphic disorder, hair pulling or trichotillomania, and excoriation or skin picking disorder, also found much more frequently with OCD than we'd expect by chance. And then the last part of that burden is that OCD is typically a chronic illness, often lifelong. So much so that going into complete recovery is really a very rare exception. I want to think about that for a moment. Recovery is a rare exception. That doesn't mean that people with OCD won't make huge functional gains and make what we call a functional recovery, where they regain back control of their life and live a meaningful life. But in terms of symptoms being gone and gone for good, that's not something we hear often in OCD. How common is it? I'll show you a few faces. I like that picture. I just put that in there. And of course, we should not forget this one, who went public acknowledging some OCD traits long before he was in the Oval Office. Okay, just want to mention that. So how do we treat OCD? Well, currently we have two what we call first-line treatments, meaning treatments for which there is great evidence about effectiveness, paired with very low risks or no risks in terms of adverse consequences. And those come down to a form of psychotherapy called cognitive behavioral therapy, which we're going to be hearing more about from Marlene Topschiff in a moment, and drug treatment, which I'll tell you a little bit more about. Now, there are other kinds of treatments which are increasingly looking very helpful, and so you'll be hearing about some of those that are in the lead as well. But these are the two that are best best seen as having the strongest evidence, as shown by the number of people they help. So this is a graph just indicating for you, for example, that with a number of these medications, we see about 50% of people typically responding. That's actually not so great when you think about it, right? Although if people go on to try multiple medications, those odds will go up to about 70%. But that leaves a lot of people out in the cold with regard to medication alone. Now, our psychological treatments, cognitive and behavioral therapy, which we usually talk about in a combined fashion as CBT, in fact can help up to 90% of people who get them. So we have a challenge as a society to make sure these treatments are more widely available than they currently are, and that is an ongoing issue. In terms of the drug treatments, the best first-line medications we use are a family of antidepressants called the SSRIs, or selective serotonin reuptake inhibitors. And these are all drugs that were developed first for depression, but work beautifully as well for other anxiety disorders and OCD. Pardon me, and on this slide I've just got names of the common approved medications in Canada that all work about equivalently for OCD. But I want to just briefly point out that sometimes both drug therapy or pharmacotherapy and outpatient psychotherapy, CBT, are not going to do the trick. And that's when sometimes we may look at other types of psychological treatments, which is why I'm so delighted you're going to hear more about mindfulness and meditation tonight, but also other biological therapies, which we're going to be rounding out the evening with. And I'm not really going to tell you anything about them now because Ben, I believe, is. But these are all treatments that we describe as neuromodulation, ways of altering brain activity more directly. And that is a really exciting new area for OCD. So let me just close out a little bit by telling you about what goes on in the brain of people with OCD. And this is an area where really 30 years ago we would have had virtually nothing to say. Most all of the information dates the last 20 years or so. But one of the earliest studies, actually, the earliest study was done by Lou Baxter and the team at UCLA in the US. And he looked at people who had had either drug therapy or behavioral therapy for their OCD, these two first-line treatments. And he was the first to show in this series of people that their brains look different in terms of their activity before treatment and after treatment. So if I show you for a moment, red here is an area of increased brain activity, and blue is decreased activity. And here we have somebody pre-drug therapy. And what I'm hoping people can appreciate is that these areas up here, which have a bit of a red center pre-treatment, in this individual, lose that post-treatment. That's part of the orbitofrontal or prefrontal cortex. We also have an area here, which you can see has that red or very hot center, very active pre-treatment, showing again a real decrease activity after treatment. And that's a brain structure called the caudate. What was more, this was the first study that showed these same brain changes with a form of talk therapy. And that was at the time a very contentious finding, and still does get challenged by people who say, how can a talk therapy influence brain function? But it does, and we see exactly those same changes, including in this individual, real cooling off in this area. I think you can appreciate how it goes from yellow to green, and that's the thalamus. So what can I tell you about these structures? What I can tell you is that we know they form an active brain loop in which they modulate each other's activities. So this is a normal brain circuit that we all have, but we see some changes in activity in people with OCD, such that this loop normally has some inhibition from the striatum to some of these other structures, which kind of keeps it modulated. But it's thought that in people with OCD, they lose this inhibition that was here on the right. And when they lose that inhibition, they end up getting pushed into kind of an overdrive, and we see persistent overactivity in this brain circuit. It's kind of interesting. And what we know about these structures makes a great deal of sense in terms of why they'd be overactive. active in OCD. So in terms of the orbitofrontal cortex and the frontal lobe, right here at the front of the brain, we know it's very important in areas such as error detection, working memory, and making complex decisions for goal-directed behavior. The striatum, or the caudate, one of the structures I showed you was overactive, is really important in kind of breaking things and in routine activities that don't need to be normally thought about actively, consciously. And the thalamus also brings in the emotional tone and is part of controlling the movement routines in the body. Now that's really oversimplistic. I'm a little embarrassed to be saying this in front of one of our neurosurgical colleagues, but Ben's going to correct me later and tell you the real dope on this. Now, I couldn't not mention genetics because that's been an area of my passion for about 28 years in my research. And this is theoretically a strand of DNA saying no one understands me, which is still somewhat true, although less true than 30 years ago. But what is interesting is that although we've identified a whole host of genes that we think may play a bit of a role in risk for OCD, including a gene in the glutamate system. This is an excitatory brain neurotransmitter that sends signals from one brain neuron to another. In the serotonin transporter, which is actually the site at which our SSRI medications work. And, I'm missing one. There's a dopamine receptor. There are a few dopamine receptors that also come up as interesting. What is really interesting is that there's now research where people have tried to tie together these genetic risk factors, which individually don't predict a whole lot of variability, and have shown that they influence the activity in certain underlying brain regions. So we're just beginning to tie this whole picture together, but I'd say it's still early days. What's even more interesting have been newer efforts to try and see whether we can use functional brain imaging, like those very images, early images I showed you by Lou Baxter's group, to actually predict in advance how people will respond to treatment. And this is just one example of a study that came out last year where they did these active brain scans and extracted the data and used it to predict who would respond to treatment about 70% of the time, which is certainly a lot better than chance. So do we have a long way to go? We do, but it's beginning to look like we're en route to doing better with this. Although it's possible that we need to combine a whole variety of data sets to really understand the complex picture in OCD. So let me summarize. We've talked about OCD as a common disorder, typically fairly chronic, typically quite severe in its impact on people, but that can be effectively treated with medications and cognitive behavioral therapy. We've also talked a little bit about how it's associated with changes specifically in the underlying brain structure and even more importantly with brain function. And hopefully just touched on this idea that in future neuroscience research may give us the tools to better predict what kind of treatment before people embark on it. Wouldn't that be wonderful if we saw that in the next 10 or 15 years? Okay. On that note, I just want to also mention we do have a website which has a lot of useful information. If anybody is interested, they can go straight to our website. We actually have a patient handbook with more information about OCD and upcoming events. Thank you. So I'm going to ask people not to ask their questions right now, but to certainly pass on cards. So if anybody has questions, just put your hand up and somebody will come around to collect them.
So I'm really going to be touching on the idea of cognitive behavioral therapy, CBT for OCD. And I know our theme has an element of what's new. So I'm going to try to capture some elements that we build into our CBT work that are a little bit more recent and can add to some of the value and impact of this work. So the good news and the bad news is there's not that much that's new in CBT, and that's actually a good thing because we know from over 2 decades of research that CBT has very long-standing results for many different psychiatric illnesses, OCD definitely being one of them. We'll talk a little bit more about that. So I wanted to start off with a simplistic overview of what CBT is and how it works kind of generally, how we can think of these connections, and how we can also think of them in the context of OCD. So let's say we have a situation where someone sees a dog, as an example. They might have a thought such as, what a cute dog. And then the feeling would often be elicited, would be one of general happiness, eagerness, and they might go over, give the dog a hug, or pet the dog. Now let's say, same situation, but a very different thought, that you have the thought, that dog will bite me. The feeling would be often one of terror or fear. I myself don't really like dogs, so I might be more in this category. And you might run away from the dog, avoid the dog, cross the street, etc. Now, this is sort of our classic CBT triangle, where we look at that connection between thoughts, feelings, and behaviors, and we have a variety of strategies that we look at these things, we can challenge some of these thoughts. And I wanted to illustrate how OCD has this other interesting element to it, where we think about thoughts about the thoughts. So I've added to our classic CBT triangle. So let's say, again, we see a dog in this situation, and we have the thought, that dog will bite me. Now let's say we have a thought about that thought, which sounds like I'm responsible for other people being safe. So it takes that thought to a different place, where that individual might then not only worry about themselves, but they might have thoughts that they need to care for others. They need to protect others from the dogs that are out there. Fear might still very well be elicited, but the behavior might look different. There can be some avoidance, but there can also be this feeling of needing to protect and needing to guard other people. And OCD is very complex in that way, that we're not just looking at these kinds of automatic thoughts that come on the scene. We also work with people really to go to the thoughts about the thoughts and to look at those other kinds of elements, such as feelings of being responsible for other people. So it's just a very simplistic kind of overview of how OCD has this other element, where we look at these thoughts about the thoughts. We call them appraisals. You'll see them described that way in the literature. And they have a variety of different thought appraisal categories that we look at within the context of CBT. So let's look a little bit more deeply in terms of the CBT model of OCD. And I'm using a contamination example, often because it's a little more concrete to be able to look at it that way. But certainly there can be other elements of OCD, as Dr. Richter touched on. So let's say there's a trigger in your environment, such as my phone falls on the floor. Now, potentially, I myself could even get some unwanted thoughts, images, or urges about my phone. But we're going to see how an individual with OCD will get into a much different kind of loop. So they might have a thought, there might be dog poop on the floor. And then they're going to start getting these thoughts about the thoughts. If I don't clean my phone, then this dog poop could spread. It could spread to other people, making me a negligent individual. It could go to other places or items, and I'm not going to be able to handle that feeling of disgust. Distress and anxiety would certainly increase at this point, especially as the thoughts start spinning to these other places. There could be different types of behavioral rituals, compulsions of cleaning, reassurance seeking, asking people, does my phone look clean to you? Do you think something might have happened to my phone? Could it be contaminated now? There could be avoidance behavior. Sometimes people will stop using their phones, have their phones in certain protected cases, cleaning their phones. And that's what this next box highlights, just the excessive and different types of behaviors that will go along with these kinds of thoughts, the accompanying compulsions. And people get stuck in what you see here as this OCD loop in terms of the thoughts, leading to the thoughts about the thoughts, the anxiety, and the different types of compulsions that arise. And it can be very difficult at times to get unstuck and get out of these types of loops. So we want to be able to take away these compulsions to try to break these cycles, thinking about more our behavioral and cognitive cycles. How do we get into those loops, and how do we try to shake those cycles up. And there's various strategies that we'll use, and that I'm going to talk about in a moment, to try to be able to allow people to be exposed to these kinds of triggers in their environment, and then prevent them from having these very types of responses in this box. So I'm just focusing for tonight very briefly on this idea of exposure and response prevention, which is one element of cognitive behavioral therapy, more of a behavioral aspect of it. Certainly not to not give honor to all the cognitive strategies that we use, but just in the interest of time, not getting into all those different kinds of tools. So on one end of this sort of spectrum that I'm showing, we can imagine this idea of, let's say we were to fall on the floor, our phone falls on the floor, something ends up in that sort of contaminated space that we don't want. It would be followed by excessive showering, maybe use of chemicals, throwing out clothing. And then we can imagine being in a space which we could think of as maybe a more balanced space. So falling on the floor, followed by wiping our hands off, continuing on with our day. And then we can think of how we do exposure and response prevention, which is often conceptualized as sort of going beyond typical and going to a place where you're going to do things that you might not normally choose to do, but really for the sake of not allowing OCD to be what makes a choice for you. So the idea is going beyond typical and then showing yourself that I can roll around on the floor and I can cross-contaminate that feeling of germs or dirt to all of my personal belongings and feel okay with that. I might not choose to do that every day, but I can do it and learn from it and see what that's like. And that has that element of going beyond that yellow circle in the middle in terms of what most people would typically do. And we talk about doing this to not allow OCD to call the shots, to show OCD that you can go beyond what's comfortable and what's typical. What I wanted to focus a little bit on today really is just that idea of how does exposure response prevention work. And we have different models and conceptualizations of this that we think about and pull into our therapeutic processes. So this is a very lovely graph of what we call habituation. And it's really the idea that as you continue to expose yourself to triggers and prevent yourself from responding in the way your OCD wants, that your anxiety will diminish over time. So you can look at this very first kind of graph with a spike, a large spike in anxiety, perhaps the first time that you're exposing yourself to a trigger. And then this kind of, sorry with this, but it's kind of this gradual, kind of slow decrease in anxiety or distress. That could be anxiety, it could be fear, it could be disgust. People have different types of distress when they are exposed to their triggers. And you can see the idea being over time, the initial spike in anxiety is less, and the time that it takes to recover is less as well. This is a beautiful textbook model of what we think of as habituation. The individuals I work with who have very treatment refractory OCD do not very often experience this type of a lovely descent. So then we think about other elements that we can bring in to help. So I wanted to just touch on the idea of, Jonathan Abramowitz talks about this, Michelle Krosky has done work on this, the idea of inhibitory learning and how does that fit in with what we can think about. And this can be helpful for individuals that don't necessarily habituate to think about other ways that they can move through the exposure and response prevention work. So we can talk about this idea that anxiety doesn't really need to decline because we're saying that there's nothing dangerous about anxiety. So can I tolerate feeling anxiety while also doing these other kinds of ERPs? So we do talk about that and recognizing that there's nothing dangerous about anxiety. It's okay to feel it, even though it's very uncomfortable. In an inhibitory learning model, we might not use an exposure hierarchy. So the exposure doesn't have to be graduated. You could flip around. You could do things that are hard. You could do things that are easy, with this element of surprise and learning being very key ingredients, and this idea of being present during the exposure. So instead of thinking how distressed was I, how present was I throughout that exposure? And remaining in the exposure until potentially the feared catastrophe didn't happen. And I say potentially because sometimes the feared catastrophes can happen, you know, 50 years from now, and we can't wait that out. So it's that idea of, can I remain in this and still do things that are important to me and learn from it? And that's also where an acceptance and commitment therapy, what we think of as a values-based type of exposure model, can also play a very important role when doing this kind of work with individuals. So really focusing on exposure work that is meaningful to you, and it can be the exact same kind of work. I mean, in terms of the contamination work, why is that meaningful? What will that give you to be able to work with those kinds of things that fall on floors, for an example? And exposure really becomes completed in the service of your values and your life goals, and having those meaningful conversations with people to really best understand why we're doing the work. And if the ERP list in those cases can become based on what emerges from our values. Again, symptom reduction is not really the goal, but the goal is being focused in the present moment, whereas symptom reduction can certainly happen over time and with practice, but it's almost conceptualized as a bonus as opposed to the goal of the work we're doing. And again, that idea that anxiety is not dangerous, we don't have to strive to get rid of it. This is just as, I just chose this to throw up here. It's a sample ERP plan. I put morning and afternoon. We work on that within the program, but really without kind of going through all of it, it's really the idea of working on, if you're working on an area of contamination and hand washing, doing multiple things sort of throughout the day, layering things on, touching linens, touching bins, touching a floor, eating a snack after. So just working with it throughout your day in a way that's meaningful. So in terms of the key points, just to kind of wrap up this part of the talk, like this talk, we need to expect to feel uncomfortable. There's no way around that. Unfortunately, I often tell clients I work with, if I had a magic wand and I could take that away from you, I would, but I can't. And it's okay, because it's okay to feel anxiety. It's uncomfortable, but it's really not dangerous. The pace of exposure certainly can be gradual, but it doesn't necessarily have to be. We can work quickly, and that's okay too. Try not to fight your fear. Do the opposite of what OCD wants, and try to do as much ritual prevention as possible. The idea that it's hard, but it's worth it. And I often say to the people I work with, life is an exposure, and we really need to embrace it. I just wanted to end on this quote, which I really liked when I saw it. Being brave isn't the absence of fear. Being brave is having that fear, but finding a way through it. Okay, that's it.
Thank you so much, Marlene. And again, a reminder for people who have questions, feel free to write them on cards and put up your hands, and the volunteers will come around and collect them. So now it gives me great pleasure to welcome Neil Rector. And Neil is our Director of Research for the Thompson Center. He's also a real leader internationally in cognitive behavioral therapy, not just for OCD, although of course that's the only thing that really matters in my worldview, but for anxiety in general, and in fact in other areas such as psychosis. Neil's been a recognized leader for many, many years, and we're just really honored to have Neil as part of our program. Tonight, though, Neil's going to be telling you a little bit about some of the research that's out there in the use of exercise as a kind of novel technique for helping people with OCD. So let's welcome Neil.
Hi, good evening. The history of treating OCD in the modern period of doing research to find which treatments are effective really boil down to the two treatments you've already been hearing about, medications and CBT. And we've really moved along forward quite well in the last 2 decades of developing medication treatments that work, but also delivering CBT treatments that work. We feel like we've got 2 very good treatments, but for a condition that affects 1 in 40 people, having a couple very strong supportive treatments isn't a whole lot. There's also the problem that perhaps many of you know this in the audience. These treatments are hard to access. They can be very costly. In spite of their effectiveness, Dr. Richter showed you that we're still talking about success being about 50% of people reducing or having a 50% reduction in symptoms. But the majority of people who experience OCD will go on to continue to have symptoms in spite of responding effectively to treatments. So it really does behoove us to continue to develop treatments that are accessible, relatively non-costly, and that lead to effectiveness in the reduction of OCD. And just to highlight at this current state of knowledge, we have 2 treatments in all leading international guidelines. That when we're talking about the evidence-based treatments for OCD, we're talking about the antidepressant medications for the most part and CBT. And the story about exercise and OCD is a very short story. I'm going to tell you more about the promise that it holds than a slam dunk, large body of evidence at this state of evidence. But here are the Canadian guidelines for doing physical activity. 150 minutes a week of moderate to vigorous aerobic physical activity. So that's, 15 times a week at a minimum recommended duration of 10 minutes or more, or about 5 proper workouts of about 30 minutes or more a week. How many in the audience feel like they meet these Canadian guidelines? That's about 6 to 7%. And research that's looked at the degree that Canadians are exercising shows about 15% of people meet this fairly rigorous standard. But when we look at research looking at the benefits of exercise, we certainly know that exercise reduces a whole range of physical illnesses. It protects probably against about 25 chronic physical illnesses. And we're increasingly learning that exercise is helpful for the state of depression. So when we look naturalistically at how people are living their lives and the exercise they're doing, and we look at correlations between these variables of people living their lives, we do see that regular physical exercise is associated with decreased prevalence of major depression, panic disorder and agoraphobia, social phobia, as well as specific phobia like the fear of animals or insects. And some studies have actually shown that when you're exercising regularly, it prevents the onset of these conditions. Another group of studies haven't looked at just people living their lives and working out in the community, but they've looked at actually bringing people into the lab and have them exercise and then see what the impact is on their emotional difficulties. And these are called meta-analytic reviews where the literature is summarized. I don't seem to have a pointer up here, but you can see that this one copy review of 23 exercise studies in depression found that doing about 12 weeks of exercise, somewhere in the order of 3 or 4 times a week, reduces depressive symptoms. And that effect is actually quite a large treatment effect. And other studies have looked at a more rigorous examination of studies in different ways, but overall, the research shows that you get a pretty good moderate to large treatment effect when you do regular aerobic exercise. And if you're experiencing clinical depression, you're likely to improve through those activities. Some studies have shown that the benefits of exercise are really on par with medications and psychological treatments like CBT. That was interesting. For those who are in the mild to moderate range. So maybe not for severe OCD, but for those in the mild to moderate range of depression, that the benefits of exercise may actually match our other gold standard treatments. What do we know at this stage of the type of exercise that's most likely to be helpful for those who are in a depressed state? Looks like combining aerobic and resistance exercise may be most effective in reducing the state of depression. Low intensity exercise tends to be more helpful than high intensity. Surprise, surprise, the more working out you do, the better you may feel. So the frequency of aerobic exercise has been linked to reduction of depressive symptoms in a dose-response fashion. And emerging research shows that maybe shorter bouts of exercise may be better than longer bouts of exercise. And we're also learning that it helps to have a workout buddy, someone who you go to the gym with, or who can also be involved in supervising your workouts. So these are some of the variables in about a 20-year depression literature looking at the role of exercise in reducing the depressed state. So this mounting scientific evidence has led in the depression area to international guidelines suggesting that regular structured aerobic exercise is an effective evidence-based treatment for depression. They recommend trying to do exercise in group modality, try and do it with support, like maybe a coach or somebody else who really knows how to exercise. Try and get in about 3 sessions a week. Try and work out somewhere in the order of 45 minutes to an hour. And try and keep that going minimally at that level of intensity for about 12 to 14 weeks. There's lots of room for different types of exercise, but we're really looking at trying to get people to exercise 3 times a week over a 12-week period, particularly focusing on aerobic exercise. And these have now made it to international treatment guidelines. So doctors are prescribing exercise in addition to medications and CBT in the area of depression because of this known efficacy. We're also beginning to learn, and this is again more recent research in the last couple of decades, that exercise is also very impactful on anxiety. So exercise, particularly aerobic exercise, reduces state anxiety, it reduces psychosocial stress, and it can reduce panic attacks in those who are vulnerable to have them. So here we're talking about just a small number of studies, 5, 6 studies done in total. But again, what we have at this state is that in each of the anxiety disorders that have been examined, doing regular aerobic exercise over 10 or 12 weeks at that frequency of about 3 to 4 times a week impacts on the symptoms of each condition. So we've got a pretty good scientific base for understanding exercise as a role in reducing depression. There's an emerging literature in the anxiety area. We still don't know very much about why it's working. It could be that doing regular exercise is a little bit like an exposure therapy model, Marlene would tell us. So if you're exercising routinely, you're actually exposing yourself to uncomfortable physical feelings. Another possibility is that exercise is impacting on these conditions through changing the brain structures that Peggy was referring to. So to the left is a fairly quiet brain, sitting, doing very little, and look at the activity in the brain following a 20-minute walk. We really do see the brain lighting up under conditions of aerobic exercise. In the areas that may be affected may be those areas that are particularly related to memory and learning. We also know that exercise could actually lead to cellular enhancement. This is something called neurogenesis in areas of the brain that have a lot to do with memory functioning, like the hippocampus. So here's, if I had a pointer, you can see in the blue lines in both the left and right-hand side of the hippocampus that following 12 weeks of exercise, you actually get an increased volume in hippocampal size, and that hippocampal improvement correlates with improved neuropsychological performance. So you can actually change the structure of the brain through exercising, and this correlates with improved cognitive activity. So at this stage, we know that regular exercise improves brain health and cardiovascular health. It may improve cognitive functioning, and it certainly appears to be effective in treating mood and anxiety disorders. What do we know about exercise and OCD? Really quite little. Two early studies looked at very short bouts of structured aerobic exercise and did and examined people's OCD level of severity before and after that 6 weeks of exercise or 12 weeks, and found that exercise was improving OCD symptomatology. And that the effects were not trivial, they actually looked very promising. So here we've got a Y box in the moderate range. This is a standard measure of OCD symptom severity. And within either 6 or 12 weeks of exercise, we're actually seeing Y box of improvement of around 30 to 40%, which is really quite impressive compared to so many other treatments that have not shown promise beyond medications and CBT. So we decided here at Sunnybrook to start a study a number of years ago where we were going to combine exercise in those who were doing our CBT treatments. So they were going to do our 15-week standard CBT treatment for OCD, and we were also going to get them to do 12 weeks of structured aerobic exercise. It was a very small sample, it was a pilot study. We measured their symptom severity pre and post treatment, along with some other aspects of their exercise engagement. We gave them a pretty standard CBT treatment the way we'd ordinarily deliver it. And we tried to give them a structured 3-week workout regimen over the 12-week period. We had people come into the lab, we figured out what their potential was in terms of maximal exercise efficiency, and we tailored everybody's aerobic program to meet their capacity. So we'd have people come in, we'd set up their maximal heart rate zone, and we'd actually ask them to have a 30 to 45 minute workout, a 5-minute warm-up period, a really good period of exercise for about 30 minutes, where you maintain about 80% capacity of your maximal heart rate ability, and then have a cool down. This is sort of an ideal aerobic workout. To show you the types of exercise people did in the study, people used the elliptical workout, they worked on the treadmill, stationary bike. Peggy, how am I doing? Getting pretty close, moving along, put the water down. But you could see that across 12 weeks, people really thought that the exercise was a doable component of the intervention they were receiving here at Sunnybrook. And they were doing various exercises that we know to be helpful types of exercise aerobically and fitness-wise. So here were the 11 participants in the study that completed the study. And you can see to the left are the beginning Y box scores, all in the moderate to severe range. And then to the right are at time 2, T2, were what the scores looked like after 15 weeks of CBT and 12 weeks of aerobic exercise. And you can see that all participants in the study were improving. And those lines really represent very significant improvement. The overall treatment effect is a much larger treatment effect than we'd expect to see alone in medications or alone in receiving CBT. So we published these pilot results showing the benefits of adding structured exercise to CBT. And we were able to directly compare our results combining CBT and exercise in the red to the 3 other studies that looked at exercise alone. So exercise does help in OCD, and it might be that you get a particularly strong synergistic effect when you combine CBT with exercise. So we took these pilot results and then we went on to conduct a much larger randomized controlled trial where we wanted to look at CBT and exercise individually as well as in combination. And we also wanted to look at whether or not CBT and exercise were impacting on the brain. We ran this study over the last 4 years, and we are still just in the midst of analyzing the data, probably know the full results in about 4 weeks. Story looks pretty good. People are getting better. The more exercise they do, the better the outcome. And we're also showing an impact on their underlying neuropsychological vulnerabilities, particularly in the area of inhibition, the area that the brain that Peggy talked about being a vulnerability in OCD. Okay, so as a summary, structured physical exercise is a feasible intervention in OCD. Our early research shows great benefit when added to CBT, and we're hoping that this can become an effective and available treatment option for those suffering with OCD living in the community. Thank you.
Thanks so much, Neil. So I assume that means if we ask at this talk next year how many are exercising regularly, we're going to see more hands up, right? Wouldn't it be nice if it was so easy to change for all of us? It should be easier than it is. Reminder, questions, just hand them in and we'll get them. Just put your hands up if you have them. And now I'm happy to welcome, there he is, Lance Hawley. So Dr. Hawley heads up our outpatient services here, and we're really thrilled to have him as part of our team. He keeps really busy offering outpatient CBT groups and mindfulness groups, which is a really new intervention he's going to tell you more about, as well as being involved in supervision and training of the next generation of practitioners, which is something we're also very proud of providing here too. Lots of psychology and psychiatry trainings. Thank you, I'm delighted, and I think you're going to find Lance's talk particularly interesting as it kind of treads on new ground.
Hello. So today I'd just like to talk to you a little bit about some of the ideas behind how to adapt mindfulness-based principles to the treatment of OCD. Anybody here heard of mindfulness? Just show of hands. Yeah. Wow, that's fantastic. So if we're going to try to connect the dots, there's a lot of different ideas about what mindfulness is, how it's defined. Obviously, we have potentially hundreds or more years of a cultural, spiritual, religious tradition that might go along with these ideas, but often the Western kind of clinical version of this is very simple, at least on the surface when it comes down to it, is that if you're taking a really close look at what's happening, people are showing up with their five senses, they're paying attention, and they're trying to be curious about what they're looking at. And it sounds like maybe a bit of a stretch because usually we're kind of almost like our own worst enemies when it comes to what's happening to us. But if you can try to be curious and not judgmental, then that seems to be kind of the right version of what we're looking at. A lot of interesting things can happen when you're in this headspace. You might find that you're a bit more open to experiences. You might find that you're adopting a bit more of an acceptance-based kind of approach to things that are important. And sometimes if you are able to do that, you might even see other interesting constructs show up, like being a little bit more compassionate with yourself, or being a little bit more able to allow experiences in and stay with them a bit longer than we normally do. So one of the ideas with mindfulness is that if I just talk about it at length, I'm probably not being really mindful myself. So if you're up for it, we might just do a very brief practice as a group. Feel free to play along if you're willing to. Feel free to say no if this isn't your thing. So if you could just maybe get into a nice and upright, sort of dignified position. No, back nice and straight, being really alert. And if you're comfortable with it, you might even allow your eyes to close. If not, you could keep your eyes open and just gaze at something in your field of view. So just taking a moment or two to be in touch with your five senses, just allowing whatever's here to be here. Just kind of taking note of whatever thoughts or emotions or physical sensations are present. Trying your best just to be curious for a brief moment or two, allowing yourself to step back and observe. You don't really need to do anything, you don't need to fix anything or try to expect that anything will change. Just trying to be present with your thoughts, any sensations. As we slow things down, just noticing your breath as it enters and leaves. Just letting your body kind of move with the breath, allowing the breath to be coming down in through the nostrils, into the throat, moving down into the lungs. Just watching and following that process as the breath breathes itself. You don't have to breathe in any particular way, just noticing each in-breath and each out-breath. And then the next few moments, becoming aware of any physical sensations that are present. You might notice points of contact between your body and the seat. You might notice how the body and breath move together. If you happen to notice any discomfort, just watching the breath as it moves down through the body, softening. Just noticing the breath as it moves. And at your own pace, when you're ready, you can open your eyes. And that's pretty much it. So you can see how maybe that experience that you had is maybe a little bit different from what we would normally do during the course of a busy day. Often we're involved in a lot of different things. We might be running around from one thing to the next, trying to put out fires and problem solve and what have you, which is completely normative. But can you imagine if you're asking someone who experiences OCD symptoms to do something like this? It's almost the equivalent of trying to do that same practice that we just did while a fire alarm is going off. Pay attention to your breath. There's an alarm going off. I can't pay attention to my breath. Thanks for asking. So it's kind of a bit of a head scratcher of why on earth would we try to consider these ideas when it comes to OCD symptom management. So as we heard earlier, there's a typical cycle that happens when someone experiences OCD. There's this aversive experience. It might be a thought or an image that starts the cycle. Someone is doing their best to try to manage that, and often the rituals make a lot of sense, at least in the moment, as a strategy someone is engaging in order to feel safe. Now, one idea about what mindfulness might be doing here is that it might help us disrupt that practice, that cycle rather. So engaging in a practice, even if it's fairly brief, might start to slow that cycle down a little bit. Maybe if we're able to be a little bit more curious and attentive to these things rather than just rushing in to try to avoid them or try to fix them, maybe something interesting can come from that. There's a few ideas that people have looked at in terms of why these practices might be helpful. So just by being more aware, using your 5 senses, showing up more often into your life, being able to understand what's going on for you, that in and of itself is quite valuable. Every once in a while, someone may have that experience of having the thought, but being able to almost kind of step back in a way, looking at the thought as an event, trying to understand it, trying to be curious about it as opposed to having the thought run the show for you. There's definitely changes in terms of how people process information, as well as effects on the brain. And one thing that people have also come across is that you can have the urge to engage in a ritual as opposed to ritualizing, which is kind of two different things. I might have a very strong urge to do something, almost like as if it was like an itch you can't scratch, as opposed to I find myself doing this, now I have to figure out what my options are. Yeah, so this is a bit of a head scratcher when it comes to how you might be able to connect the dots, but if you had a really difficult thought or image, it might be a very different experience to be able to move into it, maybe try to cultivate this sense of acceptance. Acceptance never means liking what's going on, but acceptance means that I'm going to make a choice to try to be with that experience to the best of my ability. So there might be a few interesting things that could occur if someone's able to take that approach. The awareness is important. The attentional changes are sort of like if I can be with that experience, I don't have to be running away from it. I don't have to be fixing it. I don't have to be using all of my time and effort and energy to try to stop that experience from happening. So we do see shifts in attention away from, not away from threatening material, but towards threatening material in a way that's much more decentered. So I can see it, I don't like it, but I can be with it for a few moments longer. And sometimes that leads not only to acceptance, but you might see people becoming a little bit kinder to themselves. Even one example of self-compassion is that, I don't like what's happening to me, but I understand it. I'm kind of curious about it. I can maybe give myself a break and realize that the thing I'm doing is the thing I'm doing to try to feel safe in that moment. That might be the beginning of some form of self-compassion. So if you're able to turn towards a difficult moment, sometimes people actually learn something of value. They might learn that they're a lot more resilient than they understood before. They might learn that they're able to tolerate the experience for a few moments longer than what's typical. And just to illustrate this, if you try to give up that sort of, fight or flight kind of push and pull that we normally do with OCD, you can see what it looks like. So just for fun, try to look at this cute cuddly bear just for a few moments. If you've seen this before, feel free to play along. So just take it in, use your 5 senses, and try to focus on the image. You might even be telling yourself, this is a white bear or what have you. And then now I'd like you to suppress that to the best of your ability. Absolutely do not think about it in any way. Maybe just raise your hand if for some reason you're thinking of it. Right. So this is a good way to illustrate what we normally do when it comes to OCD experiences. We want to suppress them, we want to get rid of them, we want to make sure that we put all of our time and effort into putting a lot of energy into getting rid of that experience. And unfortunately for some people, that leads to a bit of a rebound. You know, the second you stop doing that and let your guard down, the OCD comes back in its full glory. So that's what that attentional change process looks like. You know, even if for a brief moment, if I can come into contact with something that's maybe not so straightforward, and my attention can focus on it and sort of stay with it a bit longer, maybe that could have some interesting effects, which is what we're starting to see. One way that we're talking about that is that there's been a lot of research around mind wandering. So over the course of a day, your mind wanders to various topics. It may not actually be something you're doing on purpose, but it seems like with OCD, if your mind's wandering a lot, that actually might be a strategy for some people to say, like, I'm not allowed to think about it. So you might imagine that mindfulness is really the counter to that. Rather than trying to move away from it, I'm going to try to stay with it for a few moments longer. And you can imagine what that would look like in some of these scenarios that probably everyone's had. You know, anybody ever had a difficult thought about, did they lock the door? Did they forget, testify? So, you know, like the experience is probably different where it's like, I have to get absolute certainty around this. If I'm absolutely certain, what does that mean? Well, I'm going to go back and check. And I'm pretty sure I checked properly, and then you're 10 minutes down the road. Oh, did I check? You go back and do it again. So that's the cycle that we usually see with people. So if it's something where like I'm having a very difficult thought about whether or not I lock the door, I'm going to try this other approach because maybe Lance yabbered on about it. There's something to it. So trying to return my attention to what I'm experiencing in this moment. I see the thought, I don't like it, but I can come back to my base feeling grounded and secure. There's the thought again. It's almost like you're kind of playing a bit of a tennis match. And there seems to be something in terms of those attentional processes and the way they affect the brain. And we're also seeing that in our own, we'll get to that in a moment. This idea of decentering is like, I can see the thought over there, I can have that experience, I can step back and be curious about it. And by decentering, I'm not doing great for time. 5 minutes. Okay. Again, maybe something interesting happens. I can see the thought, but I'm not the thought. I can see the emotion, I can see the physical sensation. I'm feeling a very strong urge to go and do that thing, and I can observe that as opposed to I'm doing the ritual. So this is really the basis for acceptance, which again, acceptance doesn't mean liking the experience, but trying to approach these situations with your 5 senses because the alternative is often exhausting. I have to fix it, I have to negate it, I have to suppress it. So as was mentioned earlier, we've done some interesting research around how does this work with OCD. There have been some preliminary studies, some single case studies, a few larger scale studies, and then a few RCTs that were showing that there's something to this when it comes through OCD. In our study, we're actually seeing quite decent effect sizes in terms of OCD symptom reduction when people were receiving MBCT treatment here. And the good news was that it wasn't all that different if people have had CBT before and then did mindfulness, or if they were just doing MBCT as a standalone treatment. So in both cases, the effect sizes are pretty good. So this led us to think, you know, what might be the next logical step. And we're thinking about different ways to measure what's going on in mindfulness. So self-report inventories are always helpful. We also came across literature looking at how EEG-related brainwave changes occur when someone is experiencing OCD and when they're feeling a bit better as a result of treatment. So there's this literature that was looking at how mind wandering might relate to different kinds of bandwidths in terms of EEG frequencies in the brain. So that's just basically a way of reading the brain's activity and trying to determine whether or not that's changing as a result of engaging in meditation. We came across this device called the Muse, which is a headset that connects with smartphones through Bluetooth. And basically the idea was that it was picking up EEG signals across the front of the brain. And it was also a very user-friendly kind of interface. People could do any sort of practices they wanted on their own. You know, they could do it whenever they had a free moment or two, and it plugs into your smartphone, gives you a bit of almost like gamifying the experience, giving you some metrics in terms of what was coming from the practice. This works. The sound isn't really essential. And there's even third-party apps that allow you to actually see what your brain's doing while you're practicing the meditation, which I think is kind of interesting. Because, you know, if you're like me and others, you probably don't have the opportunity to just sit down 45 minutes to 60 minutes per day in a formal way. So this is really kind of a very user-friendly experience in terms of what might be happening to the brain while you're meditating. So this is just one user's example. So thankfully, we actually saw some pretty decent results in terms of what's going on in the brain. So we had two groups in this study, people who were assigned to the muse condition, meaning that they would be practicing meditation regularly throughout the week. Thanks, time's getting short. And people who were not getting the device until the end of the study. So everybody got the device at some point. For the people who were practicing regular meditation, we saw that there was decreased mind wandering, and that was picked up in terms of alpha and beta EEG signals. So the mechanics of that is actually not all that important, but I guess the take-home message is it not only led to OCD symptom improvement, but it also affected certain bandwidths in the brain, which are associated with improved attentional processes as well as relaxation and meditation. And this is just one way of looking at it. So if the brain is giving off a signal, that signal will change over time. And the intensity of that signal was changing for people who were meditating regularly. We also looked at self-report information in terms of what might be leading to those changes. And we found that there was, so there's a measure called the 5-factor mindfulness questionnaire, which is a really interesting measure that looks at different things that might emerge when someone meditates. And we found that the people who were gaining the most improvement in terms of their symptoms were showing up on a scale that showed that they were less reactive to inner experiences. They were still having the same experiences, they were probably just as aversive, but it's all the suffering that goes along with that experience that seems to have changed. So not too far off time-wise. This can be a very easy set of ideas to implement. It doesn't mean you have to go to a mountaintop somewhere or sign up for a program or what have you. You know, it can be very brief things that might be possible throughout the day. Actually taste your food as you're eating. Maybe just taking a few moments to stop with something that's interesting that's unfolding in front of you, allowing a bit of space for that. Sometimes when we're feeling really overwhelmed, coming back to your breath and body is a way to ground yourself. And maybe every once in a while, if there's an OCD thought showing up, treat it like an experience that you could observe. So I'm going to be trying to pay attention to it and be curious about it, even though I don't really like what's happening. Thank you very much.
Thank you so much, Lance. And again, questions, just put up your hands. I'm sure there'll be more, and we have a good collection of them already. And now, last but certainly not least, I want to welcome Dr. Ben Davidson. Dr. Davidson is with the Division of Neurosurgery here at Sunnybrook, and now with the Hartwell Center for Neuromodulation. And we're really delighted to have a neurosurgeon's take on using some of these new neuromodulation treatments or ways of actually directly affecting brain function as treatment alternatives for those with the most severe and resistant to treatment, OCD. Thank you, Ben.
Okay, good evening. I'll try to keep it fairly brief. My name is Ben Davidson. I'm a neurosurgery resident, so I'm my 4th year of residency, and I'm working on a PhD right now related to neuromodulation. I'm going to talk to you, as Dr. Richter said, a little bit about some neurosurgical options for severe, very severe treatment-resistant OCD. So in cases where individuals have tried, all kinds of pharmacotherapy, CBT, often inpatient therapies, there are a few other treatment options, and I'm going to speak a little bit about that. So here we are. I'm working in a group called the Hartwell Center for Neuromodulation. I'm just going to speak about a little bit of the work that we're doing, but it actually represents, there's a huge group of a huge team, a multidisciplinary team. There's just a few of the individuals involved. So everything I'm talking about is not just me. It's a huge group. So I wanted to start by touching on something that's extremely important to the work that we're doing and also important to everything that's been mentioned so far tonight. Neuroimaging dramatically shapes everything that we're doing. Here is just a few modalities that are used commonly in neurosurgery and in other areas of psychiatry. Can I point this? Yes, I can. Okay, so just up in the top corner, just briefly, this is something called positron emission tomography that we use all the time that looks at glucose utilization within the brain, looking at metabolism in the brain as a correlate for what areas of the brain are more active and what areas are less active. Dr. Richter actually touched on that really nicely in her talk, and some of the abnormalities seen in OCD. And the other top corner is something that we're doing a lot right now, which is called functional connectivity. So it's looking at which areas of the brain function together and oscillate together to try to better understand networks within the brain. And there's many other neuroimaging modalities. I'm going to speak as well about this thing down here, DTI, diffusion tensor imaging. And that shows which areas of the brain are connected to each other. It maps out white matter tracks in the brain. So again, Dr. Richter actually did a lot of work for me by talking about the neurocircuitry of OCD. I'm not going to get into all of the details of it, but she already nicely outlined the fact that when we talk about a circuit in the brain, usually people are talking about a circular circuit that involves a few neurons, starts in one area of the cortex, projects to a central region. So in here I've showed it in green, the basal ganglia, a few different regions. Basal ganglia. Another neuron then projects even further to the center of the brain, to the thalamus, and there's different regions that are implicated in different types of mental illness, and then projects back to the original cortical region. The reason I'm showing you this is because this is important in some of the treatments that I'm going to talk about in a moment. Okay, so I'm going to speak mostly about two types of treatments that we're doing right now at Sunnybrook. The first one is called focused ultrasound, magnetic resonance guided focused ultrasound. We're very excited about it. Actually, Sunnybrook is the world leader in focused ultrasound, so I'm going to speak a little bit about it. Many people aren't very familiar with it. And something else we're quite interested in is deep brain stimulation. So I'm going to speak a little bit about both of those. So focused ultrasound is a fairly new technology that allows us to essentially perform brain surgery without cutting the skin. So focused ultrasound is now fully approved and used all the time in the treatment of essential tremor, and now it's being used as well to treat treatment-resistant depression as well as OCD. The concept is that an individual wears a helmet that has about 1,000 small ultrasound probes on it that can be aimed at a precise region in the brain and actually heat up that region of the brain by about 25 degrees to make a very small lesion about the size of a green pea or maybe even smaller. And again, it's done very precisely and the individual's awake at that time. So it's quite safe. We do it in the MRI so we can watch in real time as we do it. And so this is being done to essentially abolish essential tremor. And now we're using this in the context of clinical trials to precisely target some of the neurocircuits that are involved in OCD and interrupt those pathways by making, again, a very small lesion. So here, I'm not sure how well it shows up with the contrast there, but I'm trying to show you what a capsulotomy lesion looks like. And this is what we're doing in the context of OCD. The blue arrows are pointing to the lesion. So this is the first day after a procedure, about the size of a lesion. And again, I keep saying it, a green pea, just to give you a sense of the size. All the work that we're doing right now is in the context of small phase 1 clinical trials. These are some preliminary results in a few patients that we have long-term follow-up data in, but we have many more patients that are a little bit earlier on than this that I haven't shown. But on the y-axis here is again, it's been mentioned tonight, the y-box score, which illustrates someone's OCD severity. But the thing I would draw your attention to that we're actually the most excited about is the second and the third points I've listed here. It's that focused ultrasound is allowing us to do procedures that have been done for decades now in OCD, but it's allowing us to do it in very, very safe ways. So we have not yet had a serious adverse event, no hemorrhage, no stroke, and perhaps even more importantly, we've had no neurocognitive, personality, or other forms of adverse changes. And it's probably because the focused ultrasound technology allows us to get directly to the region of the brain that we're going after without passing through any brain tissue on the way, which is really excellent. I'm briefly going to tell you about deep brain stimulation as well. In case you aren't familiar, it's also used in movement disorders all over the world. It's probably been done, I've said 150,000, probably 200,000 times now for Parkinson's disease in cases where individuals have stopped benefiting from their medication. We're now using deep brain stimulation to target specific circuits in the brain to interrupt aberrant activity. So in the case of OCD, the circuits are quite well mapped out, so it presents a number of promising targets that we can place an electrode into very precisely and interrupt those circuits. Yeah, I think that's all I was going to say there. I just wanted to show you a few interesting images from some research that's going on. So in deep brain stimulation, we're doing a lot of research using tractography. So here I've just shown an image borrowed from some other researchers. If you took a number of different patients that have had deep brain stimulation for OCD and overlaid all of their electrodes on the same brain image, you'd have kind of an image like this. And this is sort of the region that's being targeted in this particular study. And this is actually the same region we're targeting here at Sunnybrook in our work as well. You could zoom in at the tip of any one of those electrodes and you actually see these little gray regions. And a nice thing about deep brain stimulation is that it allows the clinician, in our case, it's generally a psychiatrist who does the programming. We're quite involved in it as well, but it allows the clinician to, based on symptoms, to adjust the amount of stimulation being delivered. So increase it, decrease it, or change other settings, and actually control which of these contacts the electricity will come from. Then you could take that individual's DTI or diffusion tensor imaging scan that shows all of the little white matter connections in their brain. So you can take those images and then you can essentially figure out which white matter tracks are being stimulated in that patient. And you can associate each individual track with the likelihood of that patient improving. And then you can start to prospectively figure out exactly which regions in the brain should be targeted in which individuals and start to personalize how you might target the brain in each person. So you can see here there's a graph that's basically illustrating that the amount of functional or structural connectivity between the stimulation and a specific region of the brain actually correlates with how much people are improving as a result. And you can generate all kinds of beautiful images with it. So here's another image where essentially the red or sort of pinkish fibers here are associated with a positive response to deep brain stimulation, and the other color, the purple fibers here are associated with a negative or non-response to deep brain stimulation. So obviously there's a lot of, giving sort of a quick overview of some of the research that's being done in this field. You can talk about this for hours and hours and hours, but it's an interesting technology, and it's also something that holds a lot of promise for individuals with severe refractory OCD who have likely tried a lot of the things that have been discussed already tonight. This isn't something that we just sort of jump into when someone first presents with OCD. So I'll conclude now. So as I've been saying, but as people tonight in general have been saying, advances in clinical neuroscience as well as in neuroimaging have contributed to greater and greater understanding of OCD. I didn't talk a lot about the neurocircuitry of OCD, but all of this work is based on decades and decades of neuroimaging research that have helped pick targets within the brain. Diffusion tensor imaging has assisted our surgery immensely, helping things like deep brain stimulation. And over time, it's our hope, and basically what my PhD is focused on is trying to do things that have been mentioned already tonight, trying to predict responders to these kinds of treatments before they even have the treatment. So in other words, be able to tell someone, your chance of significantly improving by 12 months from this procedure is in fact 85% based on your imaging characteristics. And similarly, trying to personalize each treatment to a patient, generally based on imaging, but also based on clinical factors. And that's all. Thanks.
Have everybody come up now. If I could have all the speakers up. And I hope you all feel that you've had this really interesting evening, learning a lot about what goes on and what we can do to improve outcomes in OCD. I've got a lot of questions here. I cannot promise we will get through all of them, but I'm going to give it my best shot to get most of them covered by our wonderful speakers tonight. So, and why don't I start, thank you, by addressing a question towards Marlene. So Marlene, maybe we had a couple of questions about what's the difference between exposure response prevention versus the combined CBT? I think the difference, the terminology, that's one question.
So, okay, there we go, that's better. So, cognitive behavioral therapy is really the kind of overarching therapeutic intervention. Exposure and response prevention, if you think of the B in CBT, the behavioral treatment piece, that's really where ERP fits in. So it's not that we would necessarily only do ERP and not do any of the cognitive strategies. In an ideal world, we'd like to be able to combine them, and there's research from our center, from Dr. Rector, showing that the inclusion of the cognitive strategies really adds to the effectiveness of the ERP work.
Great, and also a question for Dr. Holly for Lens about how patients can access CBT at our center.
It's relatively straightforward. One thing I recommend for anybody who's interested is to visit our website. A lot of the information that we talked about today is available there. So for the outpatient clinic, it's a doctor referral. That process goes through our centralized intake. And in most cases, there's an assessment leading to either group CBT or MECT treatments that are now offered pretty much on a regular basis every 4 months in the outpatient service.
Thank you. A couple of questions for Dr. Rector came up around exercise, specifically about if you could comment a little bit more about benefits or differences between aerobic and non-aerobic exercise.
That's a very good question. When we started our work, it looked like the literature was splitting between resistance training, weights, and aerobic, and it looked like all different types of exercise were contributing benefits. But in the last several years, it looks like more and more research is showing the particular benefits of aerobic activity. And the explanation for this, I'm not sure I fully understand. I can map it out, but it's something about elevated heart rate, and it's maybe some of the changes we're seeing in the brain around elevated heart rate, maybe making the difference beyond weight training and resistance training. So in our program, One of the decisions we made when we started our study was, do we want to bring people in the lab and make the exercise very artificial, or do we get people exercising the way they ordinarily would based on things they like to do? So our partner was actually Good Life in our study. And so we asked people, just keep going to Good Life the way you ordinarily would, and let us know really more about the workouts you're doing. And we found the vast majority of people in our studies were actually doing, we're actually doing aerobic activity, and this is the activity that seems to be contributing the most.
Thank you, Neil. We had a couple of general questions around OCD, which maybe I'll just answer. So I think one person was asking about differences in gender, and it's really interesting because when we think of anxiety disorders, we know that these are disorders that generally are much more common in women than in men. But surprisingly, OCD doesn't follow that pattern nearly as much, and that there's just a slight majority of women with OCD. I was also asked about how common depression might be in OCD, and we know that about 60% of people with OCD will get depression over their lifetime. So very common indeed. And as well, a question about OCD and Tourette syndrome, which is not one of the disorders I mentioned. And that's kind of interesting because from a genetic perspective, the closest relationship we know of between OCD and anything else is between OCD and Tourette syndrome. And it's thought that that may reflect similar genetic risk factors underlying it and perhaps some overlap in brain circuitry. And the same may be true for depression. Maybe I'll go to a few questions for you, Ben, next. We got, where did they just go? Sorry, I just have them in my hands and I'm trying to keep these organized. So one is, about about RTMS, repetitive transcranial magnetic stimulation, and how that might work and whether it can also be used to treat OCD.
Yeah, great question, and sorry I didn't talk about that, partly due to time and partly because I am talking to the surgical side of things, so I'm not as involved in RTMS, but absolutely. TMS is another important investigational treatment for OCD. A particularly interesting thing with OCD and TMS is that for a while there were some limitations with how deep in the brain TMS could reach, because as a magnet, it's generally easiest to access the superficial aspects of the brain, which for a long time were thought to be more amenable to depression treatments because there's regions on the superficial part of the brain, in particular the dorsolateral prefrontal cortex, that was a clear target for depression, and maybe a little less so for OCD. But recent advancements have allowed transcranial magnetic stimulation to reach deeper into the brain, which is adding to its promise as a potential treatment for OCD. So we would like to someday, at least at the Hartwell Center, have almost a progressive potential sequence of potential treatments for patients, starting with somewhat less invasive treatments like transcranial magnetic stimulation, and should they not work, potentially more invasive treatments, deep brain stimulation.
And on a related note, based on your talk, Ben, I wonder if you could comment a little bit about, with DBS, how often people need to come in for adjustments, and how long these procedures work for.
Yeah, great questions. Again, sorry I didn't address all of those things. So with deep brain stimulation, it's kind of like a pacemaker for the brain. So it's inserted in a surgery. It takes about a 3 or 4 hour surgery. And then individuals come in generally every 2 weeks for a few months while we gradually program the stimulator and find settings that are just right for them. Then appointments are spaced out every few months, and then eventually someone might not even need to come in until every year or so. We have to replace the battery approximately every 4 to 5 years. How long does the treatment last? Well, we do know that it actually takes a while to even work. So for many psychiatric treatments, and DBS is no exception, they can actually take a while to even begin working, and DBS might take longer than some other treatments. So we think it takes often 6 months before you start seeing real benefit from it, sometimes a little sooner. As far as we know, the benefits are actually long-lasting and seem to be persistent in those that do benefit. but it take a while to see.
Thank you. I'm thinking maybe I'll ask you, Lance, to comment on this. And there were a couple of similar questions along the line of, what do you do when someone is suffering in silence with OCD? And is there any way that you can help to convince them to get treatment?
I'd like to hear your thoughts on this. It's a tough question. I guess part of the context is any one individual's decision of whether or not they would want to disclose this kind of experience to another person, which can often be difficult for people to do. So the most straightforward route is to really seek the help of a qualified professional. It could be your family doctor, or psychologist, or psychiatrist, to kind of help you understand what the experience is that you're having. We often try to understand that in terms of establishing a diagnosis of some kind. And then that really opens up a lot of options in terms of what might be able to be available in terms of support. There's other kinds of options if you're a caring person and you happen to notice that someone is experiencing these kinds of symptoms and maybe a bit reluctant. And from that perspective, I think it's just really being human, being able to be there for another person. Maybe putting away the judgment and trying to fix the person and just allowing them to tell you a little bit about their experience. And often that kind of support really goes a long way, I think, for most people. The treatment options we talked about, I think, are relatively straightforward, but it does really depend on whether someone is willing to actually divulge this information and seek out those options.
Yeah, so I don't know that I think you've answered it really completely, but just to emphasize that last bit of what Lance said, certainly for cognitive behavioral therapy or mindfulness-based treatments, the individual with OCD needs to be a willing partner to engage in treatment. So these treatments are only offered to people who want to be there and are willing to work on their OCD that way. The same is pretty much true of medication as well, but information goes a long way. And again, I would remind people, if they go to our website, I will try and get that slide up again while somebody else is answering the question, because I had a few questions about that. But our website, if you were to Google Sunnybrook Thompson Center, our website will come right up. And on there is a patient handbook that's free to download and print out. So at least to give them that information, which over time lead to their having other thoughts about treatment. I think I'm going to direct the next one to Marlene. There were a couple of questions about how to coach somebody with OCD and whether it's helpful in the moment to remind them that it's just their OCD, and how do you, if not, what else should you be doing?
So I think it's a very interesting question. I think it has a non-straightforward answer. We certainly do a lot of coaching in the residential treatment program, but the tricky thing with coaching is, while it can be wonderful to be able to kind of coach and support, it depends on the way that it's being carried out. So OCD can be really sneaky in the sense that it can look for reassurance in a lot of different ways. So it might be very helpful to say to someone, that sounds like your OCD talking, can we just walk away from rechecking the door, or can we just leave the house without doing our routine? But sometimes people are also looking for reassurance to kind of understand if something's safe or if they need to not be anxious about something. So we always want to be thinking about what type of messages we're sending our loved ones when we do the coaching. And if you're able to be working with another healthcare professional, it can be extremely helpful to have them help show you a coached exposure and response prevention session, and then you can really use those skills to be able to continue on the work on your own. And that's something in our program, and I know in other outpatient services as well, we'll work with family members to become coaches in a way that's beneficial, but also that's a way that doesn't burden the caregivers and family members that are involved. So I don't think it's the most straightforward answer, because you want to look at all the different facets coming from that individual and what their OCD is hoping for in terms of the coaching experience as well from a family member in particular.
Thank you. I had a couple of questions about medications. So one was about physical and mental side effects of taking antidepressants. And indeed, if you're taking medication that is going to change the levels of the brain transmitters and change brain function, it's probably not a big surprise that for most people there are some side effects. But the important thing is that we're only going to stick with a medication that gives us a really good trade-off between benefit and limited side effects. And that will vary from person to person and from drug to drug in the same person. So it's really important not to give up if somebody takes a first drug or two and has a number of common side effects that are quite problematic for them, because they may very well go on to a third or fourth drug and find a much better compromise with very minimal side effects. Common side effects being common, we talk about things like feeling a bit sleepy or sedated, getting a tremor or a bit of shakiness, a bit of increased sweating, a bit of diarrhea or constipation. Sexual side effects are unfortunately fairly common with these medications. None of these are permanent and all go away if you stop the medication after. So the drugs are very safe, but that doesn't mean they won't have significant nuisance value in some cases. And the other question about medications I got was whether people get used to them and what happens if the medication is removed. And on a related note, can people get addicted to these medications? And so the point I always like to make is that we don't speak about addiction for people getting treated for diabetes or hypertension. And yet we know that if you take away the medications, the illness is no longer being treated and they'll get worse. And so treating OCD in the brain is exactly the same thing. People don't get addicted or dependent on the medications, but if they're withdrawn, particularly if they've only been used for a fairly short time, the likelihood of the brain going back into that previous dysfunctional circuit that we showed before is pretty high. Whereas usually our thinking is that if people have gone through a year or more of sustained benefit, they're more likely to maintain those changes in a more long-term way. There was a question about getting copies of the presentations, and generally we haven't made the slide decks available, but having said that, all of these presentations will be going up on the Sunnybrook website. I don't see Monica's in the room right now. Yeah, usually within a week or two, Monica? Thanks so much for that, Monica. Another question, I think we have just a few more minutes, but good. I wonder if somebody wants to talk about OCD and its impact on children and adolescents. Anybody feel comfortable commenting on that one?
We're mostly adult clinicians.
We can speak to the superficialist.
I mean, Peggy will help me here.
Yeah.
I mean, we heard that onset patterns in OCD tend to be bimodal. Either you onset very early or you onset late. And so unfortunately, we do have a lot of young children with OCD. And in many respects, the OCD presentations we see in children don't differ very much from the patterns we see in adults. The Dr. Richter gave an overview of the types of OCD subtypes or symptom presentations we see in adults, and we see the same pattern of symptoms in children. And interestingly, the same treatments we've talked about being effective for adults are the same treatments that we see as effective for children. And we obviously want to start with non-medicinal interventions, starting with behavioral therapy and integrated CBT. And the outcomes there in the CBT treatment of children with OCD are also incredibly effective. It's a very promising outcome, research base for the benefits of CBT for OCD in children. I was going to say the CBT's been a little bit easier and make it kind of fun and interesting with cartoons and bubble boxes and things that can really engage kids. Maybe they're also using their smartphones if they're adolescents. And so there's ways of making CBT more accessible and fun in the younger groups that actually are suffering with the condition.
I think that last point that Dr. Richter makes a really good one, that we're asking people I think it's important to keep in mind that what we're asking people to do in CBT is incredibly challenging and anxiety provoking. But paradoxically, it can also be done with a sense of fun. So while they're doing something that makes them incredibly anxious, they can also, with another part of their mind, be aware that what they're doing is really good. It's getting towards that problem and helping them get back to normal life. And they can learn to laugh at the OCD. So it's very powerful and works the same way. There was also a question, Neil, I'll direct towards you, which was, I think, directed around that comment you made about exercise and whether it can be used at all preventively for OCD. What do we know about that?
So there's been a bit of work, as I showed, showing that exercise, when done regularly, may prevent the onset of mood-related difficulties. I don't know of a single study that's looked at this in the area of OCD, and we certainly haven't done that work. If we extrapolate from the overlap in the literature between depression and OCD, then you start building a very easy case of why regular exercise could lead to the prevention of OCD. If so many people have an overlap in depression and OCD, and we know exercise is helpful in preventing the onset of depression, then it's not a big leap over to think about ways that it may prevent the onset of OCD. Although, again, we need to do that research that hasn't been done.
Thank you. I think we're just about done. Maybe one or two last questions. There were a couple of questions about other kinds of treatment. I don't know, Lance, if you're the one or somebody else wants to step in. One person asked if we could comment at all on whether treatment is held more often in nature or natural surroundings. What's known about that? Want to comment on that? Using nature to enhance our treatment, nature therapy. I know that one comment I can make about that one is that I have read some literature around it in depression, not showing the scientific literature so much, but in the lay literature, or in sociological literature, but not so much in neuroscience literature. Although there's some, I believe, as well, suggesting, not looking at disease states, but in general suggesting that many people really relax in a very different way when they're in natural surroundings. And so there's been speculation that this may be something helpful, but I think we're still a ways away from that. And I guess one other question, maybe a brief one, and then we'll move on, was around the relationship between OCD and panic. We want to just talk about that, how panic attacks may come up in OCD.
Until recently, we've always thought of OCD as an anxiety disorder. So within our psychiatric nomenclature, we diagnosed OCD as an anxiety disorder because most common emotion experienced in the course of an OCD cycle is elevated anxiety. So it's not rare for people to get so anxious when they face a trigger that anxiety elevates right to a level of a bona fide panic attack. And one of the things that we're going to do in helping people with OCD is learn very early that while that's uncomfortable, it's not dangerous. So it's okay to go through panic attacks. It will be short-lived. It's not dangerous. It's natural. It's just an elevation of adrenaline. And through repeated practice, both in the session and as part of our exposure or inside of the meetings, people can become very comfortable and accustomed to going through panicky symptoms and not panic around the panic.
Thanks so much, Neil. And I think with that, we've come to the end of our question and answer session. I think we've actually done a great job of getting through most of the questions. I apologize if there's a few people out there whose questions we didn't get to, but we'll also be around for a few minutes at the end. I want to thank all of our wonderful speakers for their presentations. I think we all did a great job of covering a lot of ground tonight, and I hope you found it interesting and informative. Before we go, a few housekeeping items to tell you about. One is that there's a Sunnybrook blog called The Personal Health Navigator, which provides advice to patients about the hospital and general health care inquiries. So if you have a question you want considered, you can contact Paul Taylor. And I apologize, it's not on a slide, but it's at Ask Paul, spelled out, ASK Paul, Ask Paul, at sunnybrook.ca. So if any of you have an idea for the blog that you'd like to see answered, write to askpaul@sunnybrook.ca. I want to also give a special thank you to the exhibitors who are outside the McLaughlin Auditorium for this event. I know we were really delighted to have OCD Anonymous and OCD Canada, and I'm not sure if the Mood Disorder Association of Ontario was also out there tonight. All our groups that have various services and information available and help people with OCD. So if you haven't spoken with them yet, I do encourage you to stop by. And I also want to thank our many volunteers in the audience tonight who've been helping sort out the questions. It makes the event go so much better. It's wonderful to have you. And a special thank you to all the speakers who I think did a great job. I want to ask you to please complete your evaluation forms on your way out. And if anybody has not yet received a free parking voucher, you can stop by Our Lady at the exit and get one there on the way out. And please feel free to visit the Sunnybrook website at sunnybrook.ca for updates. Just a reminder, we also have one more speaker series coming up in November this fall before the start of the new year, and that will be on diabetes in November. And you can find more about that on our website. With that, I want to thank you all for joining us for what was really a great evening.